Well, good evening, everyone. This is Paul Saraja from Minneapolis, and I have the distinct pleasure of welcoming you to this CVI webinar on the science behind a valve designed for life. Tonight, we're joined by an esteemed faculty with Alan Zaharias, Michael Reardon, Nadir Hamid, and Omer Khalik, and we're going to be covering a breadth of topics, including lifetime management of aortic valve stenosis, various TAVR platforms, and the hemodynamic and design factors that go into TAVR valve prostheses. This is a CME accredited activity. If you choose to claim credit, you are eligible for that claim. This is the information with regards to the faculty. And again, really just a broad group of individuals with incredible expertise across imaging, interventional cardiology, cardiac surgery, and it's really just an honor to be able to have all of you join us tonight. There are no disclosures related to this activity, including no off-label use. We would like to thank Antares for supporting this activity, and also you can see below that this is accredited by CME Solutions, where you can either claim the credit at their website or go to cvinnovations.org. Our next live CME webinar will be on left main disease, and that will be next week on Monday, December 13th, also at this time at 8 o'clock Eastern, 8 o'clock Central or 9 p.m. Eastern. And if you choose to view some archived webcasts, you can also go to the website cvinnovations.org. And also, please plan on attending the next CVI meeting. This will be CVI 2022 in Denver next year. It'll be a live meeting, July 21st to 23rd. And with that, we'll go ahead and start tonight's presentation with Dr. Alan Zaharias from Washington University, who's going to be speaking to us on tissue science, hemodynamics, and leaflet durability for the lifetime management of aortic valve stenosis. Alan?
Thank you, Paul. If you give me a minute, I'll just begin sharing my slides. Perfect. So I was tasked to talk to you about the tissue science, hemodynamic leaflet durability for lifetime management of aortic stenosis. Over the next 7 minutes, we'll discuss the guidelines. What are the trends in aortic valve replacement? What do we mean by structural deterioration? And how our priorities have changed when we talk about valve replacement to our patients. So, as we all recall, the most recent iteration of the valve guidelines talk about the decision process of tissue versus mechanical valves. And we know that patients who, for one or another reason, who cannot tolerate anticoagulation or are contraindicated to have oral anticoagulation are candidates for a bioprosthetic valve, since irrespective of their age. In addition, for the patients who are between the age of 50 and 65 years of age, a multidisciplinary discussion and including the patient interaction helps us decide whether patients should get a bioprosthetic or a mechanical valve. And finally, if you're older than the age of 65, it is not unreasonable to choose a bioprosthetic over a mechanical valve. And as a result, as you can see in this slide, the trend of patients who are receiving valve replacements in the United States is increasing. Now, on the far right, you'll see that all aortic valve replacements have increased, potentially at the expense of all surgical valve replacements, as the TAVR curve has greatly continued to uptrend. Now, if you look on the left side of the screen, you'll see that the age at which patients have their initial operation clearly has an impact on their survival. In patients who are low risk, if you follow that blue line, who have their first operation at age 65, at the very least, they'll have around a 15% survival after their original valve implant. And even patients who are of intermediate risk have, on the average, around the 10 to 12-year survival after their initial surgery. So whatever we implant at an original date has to be thoughtful and has a great impact on whatever is available in the time to come. As we can see here in the patients who were treated with a transcatheter prosthetic, both in the intermediate risk and some of the lower risk patients, we can see that up to 5 years, we have appropriate survival that is quite comparable to surgery. Now, after 5 years, we begin to see that there is some amount of structural deterioration. Now, all valves are not created equal, and surgical valves have different patterns of structural deterioration depending on their manufacturing processes and the different brands per se. And even in the TAVR world, we don't necessarily have a unified definition of structural deterioration up until recently. So all registry data that we currently follow is relatively flawed. What we do know is that structural deterioration is an active metabolic process. It is influenced both by the shear stress of the leaflets, a continuous contact with a ring, in addition to intrinsic characteristics of the tissue that cause it to fail at a certain point. Now, these characteristics can be grouped in either patient factors that we have very little control over, or prosthetic factors, which we can potentially begin to choose from between prosthetics and prosthetics. But the size, the position, and the valve design are incredibly important. And as a result, if we try to focus on these items, we can potentially change the durability of our prosthetics. Specifically for TAVR, we know that the technique and the sizing will affect potentially the ability for the valves to last. There is a theoretical risk for valves that are crimped on to be fit into a sheath or potentially post-dilated at high pressure in order to fully expand the sewing ring. And changes in the stent geometry also may affect the stress of the leaflets, all of which will affect potentially the durability and the hemodynamic profile of our prosthetic. So as a result, in order to have a successful TAVR, we want to make sure we have the optimal result to begin with. When we talk about a tissue prosthetic, we want to make sure that the leaflets are treated appropriately. In general, all of the pericardial leaflets are taken are harvested originally. Then each company has their own biochemical process in which they extract the phospholipids, they potentially remove cellular RNA or debris, and then potentially bathe the tissue on glutaraldehyde. Now, unfortunately, glutaraldehyde by itself does leave some cellular remnants and also has leave some moieties that actually will then continue to calcify potentially over time as you treat patients. Now, there is a special anti-calcification technology called the ADAPT technology that is pretty unique in that it removes all the DNA, RNA, and all cellular material after its initial wash. And after being treated with monomeric glutaraldehyde, and then once again washed again and stored in a non-glutaraldehyde solution, may have an advantage to minimize deterioration and leaflet calcification. So as we go on to our next set of patients who we treat with a valve replacement, we want to make sure that we give them the longest durability and the longest life expectancy from our prosthetic. And as a result, we'll switch or we'll shift from not necessarily just focusing on procedural metrics, but trying to choose the perfect prosthetic that will include improved hemodynamics, will have a very long durability, and allow for appropriate access for either a valve-in-valve for the future or coronary access in the future. So even though we have over a decade of success with transcatheter prosthetics, and more than that with surgical prosthetics, I think we still have places to improve on so we can have a better prosthetic for the future. Thank you.
Thank you very much, Alan. Really appreciate your presentation. If I could just open it up, we'll just have to take time for a few questions here and then move on to Michael's talk. You know, when you look at the definition of structural valve degeneration, there are varying definitions, and that's one of the biggest criticisms in the literature right now, is because it's very hard to compare papers across surgical platforms as well as TAVR platforms, and it's easy to criticize each other based on your own point of view and perhaps the agenda that may be the reason for the criticism. What do you think is the most relevant definition for structural valve degeneration currently in practice?
So the definition that's currently utilized in VARC3, or the one that actually was suggested by the European guidelines, actually is quite useful. It talks not only about a change in gradient, but takes into consideration what the original gradient was. The majority of the original definitions only talked about what the resultant gradient was at the time of measurement and had no consideration to what the original gradient was. So I think that aspect is incredibly important.
So do you get a pass then if you have a higher gradient to start with?
Well, you don't necessarily get a pass, but you have to understand that you're starting at a different level than where you started.
Yeah.
Yeah,
Michael, you've been in this
yep.
for a long time. Tell us about your view on structural valve degeneration.
Well, so, you know, we've done a very poor job in surgery of doing this, because we generally define it as coming back to surgery. And a lot of these people just don't come back to surgery. And we're now starting to grade this in steps as it actually happens. And we know from the surgical literature that if you start with a high gradient, particularly if it's over 20, your risk of early structural valve deterioration goes up exponentially. And so the lower you start, the longer it's going to be before you see even moderate structural valve deterioration. We have lots of data from the surgical literature that says if you have a valve that has a small EOA and patient prosthetic mismatch, you will have a decreased survival, you'll have increased readmissions for heart failure and increased readmissions for valve reinterventions. So, you know, starting as low as one can possibly get is really important. We'll talk a little bit when I'm talking about what are optimal EOAs if you want to have a patient who actually wants to be active and not these echoes that we're doing sitting at rest.
Nadir, you see a lot in the core lab at Columbia. What do you describe in your reports of structural valve degeneration? What do you look for? How do you describe it to others?
Thanks, Paul, and great talk, Alan. I think, you know, really, as you mentioned, that really comparing from your baseline and what is, as you define, Dr. Radin, in terms of baseline, in terms of the hemodynamics, is it on the table? You know, or is it after the patient was, before the patient was discharged? I think that is very key. And I think determining that baseline transthoracic echo and the gradients, and then monitoring the follow-up of these patients. And I think it's very important and meticulous that us imagers really monitor the gradients, you know, over the period of time and compare it to the baseline. And I think the comparison, the difference between the baseline is key, I think, in terms of determining the structural deterioration. Now, of course, transthoracic echo has its limitations, and if any doubt at all, of course, proceed to a transesophageal echo, and of course, CT imaging, which Omar can also talk about it later on.
Yeah, I was actually going to ask Omar that exact question. So Omar, is it just too simple for us just to look at echo with gradients for structural valve degeneration? I mean, should we be using CT more to be more scientific about it?
Well, I think it's tough because our current data doesn't really show that there, you know, doesn't support a routine use of CT, and I'll talk about that in my talk coming up. But, you know, I think one of the issues, which I'll also touch upon, is that the changes on echo can be relatively subtle in early structural valve deterioration. And then the next question is, in the absence of symptoms, is there anything modifiable we can even do at that point, either from before that point, from the design perspective, or the procedural perspective?
Fantastic. Well, not to steal much from your slides and your presentation. I know that you're going to be going over that a little bit later. So why don't we move on? We'll have Michael give us a presentation on where we are with current TAVR platforms. Michael?
Well, thank you, Paul, and thank you, panel. It's great to be here. So I'm going to talk a little bit about kind of where we currently stand. Sorry. Where we currently stand. I'm sorry, I'm still in the hospital working. So, you know, we have really a couple of trials that have given us some pretty good data. And the most recent ones, of course, are the low-risk trials, the PARTNER 3 trial and the Evolute low-risk trials. We're now out to 2-year data on both those trials. And in both those trials, the data looks fairly good. We're up to 5-year data on the intermediate risk trials, PARTNER 2A and SURTAVI. Those trials will be taken out to 10 years. we'll talk a little bit about the Notion trial going forward. And if you look at the European guidelines right now, the European guidelines now say if you're 75 or above, you should get a TAVR. You look at the US guidelines, it now says if you're less than 65 or you're going to live 20 years or more, you should get a mechanical surgery. If you're over 80 and you're good for a transfemoral TAVR, you should get a TAVR. And between 65 and 80, we look at the physiologic risk of surgery and the biologic and the anatomic risk of TAVR.
Page operator 82201. Thank you.
So one thing that I like to point out when we start talking about treating younger patients and more active patients is this data that comes from Gorlin back in the 50s when Gorlin was working out the flow characteristics for aortic stenosis. And what Gorlin did was Gorlin looked at aortic flow on the vertical axis versus mean gradient on the horizontal axis, and then looked at it at different fixed openings. And you can see those are the blue lines. And the red lines you see are fixed cardiac work at two different flows. One is normal flow, which is about 220 cc's a second across the aortic valve. The other one is high flow, which is about 550 cc's a second. And what you see is, of course, if you have a opening of 1 square centimeter, at rest, you're at about 40, but if you exercise, you go up to 140. That's, of course, why these people die. The other thing you see is you really can't exercise to high levels until you get to an EOA of about 2. If you have an EOA of 1.5, which some smaller surgical valves have, and you exercise, your mean gradient's going to go up over 50. So 2, for younger patients that you want to be able to exercise and have a lifetime management, is a number that we should be aiming for. Now, this is Doug Johnson's work from the Cleveland Clinic. This is what I mentioned earlier. We know from surgical literature that if you start with a mean gradient approaching 20, your risk of structural valve deterioration goes up exponentially. And unfortunately, we've seen this in a number of smaller surgical valves. Fortunately, most of the TAVR valves aren't like this, but anytime we start getting up there with some of the smaller ones, that is problematic. Now, this is the TAVR platforms and the device generations that we have so far. You know, we started back with the original SAPIEN in 2012. We now are up to the SAPIEN 3 Ultra, and we've gone through iterations from CoreValve to Evolute R to Evolute Pro and Evolute Pro Plus. We have the NeoAcra, which is now being trialed in the US. Portico NG, the trial of that is done. The pre-marketing is with the FDA right now. And then the Navitor valve is being trialed in the Vantage trial right now. And of course, going forward, we have a SAPIEN X4 and a Evolute FX that are coming up, both of which we should see in the next year. Now, one thing, when we look at the two valves that are most commonly used right now, and the only ones that are available across all risk, the SAPIEN 3 and the Evolute, one of the things we see, this is Becky Hahn's paper that she published in Circ Imaging, where she went back and looked at all the core lab data from the randomized trials. And what she found is for the S3, the mean EOA was 1.66, and the mean gradient was 11.18. The only single digit gradient was in the 29, and the Doppler velocity index was 0.43. For the Evolute, we have a mean EOA of 2.01. All the valve sizes have single digit mean gradients, and the Doppler velocity index is 0.59. Of course, there's errors that can be made in measuring the EOA based on how you measure the LVOT, and mean gradients can be changed by the amount of flow. But the Doppler velocity index, of course, uses flow above and flow below and flow above, and it really represents a ratio of that particular patient's aortic valve opening to that particular patient's LVOT area. So it's really indexed to the patient. So you see one valve has an area that's 43% of the LVOT. Another one is 59% of the LVOT. Now, this is from the Partner 3 trial. This is the first trial where surgery actually won the hemodynamics, and surgery hemodynamics in this trial were actually superior to TAVR valves. When Marty and I presented this, Marty said that's because the surgeons learned to put in bigger valves, and that's absolutely true. TAVR has actually forced us to be better surgeons. This is from the Evolute low risk trial, and as we've always seen, the Evolute valves have single digits and the EOAs above 2, and certainly are superior to surgery. This is the 5-year Certavi data for the intermediate risk, and again, single digits for the Evolute valve across 5 years with no change, and EOAs that are above 2. And this is the 8-year data from Notion. And that's the Notion was a Nordic trial, people 70 or above, really low and intermediate risk. And one of the good things about this trial is at 8 years, more than 50% of the people are still alive. And so we really have a pretty good feel for this. And you can see there's no degeneration in the valve up to 8 years using the original first generation core valve. Now, if we look at the kind of superannular versus balloon expandable, no question, superannular has better hemodynamics. It always has. And this is on the right is actually the choice trial going out for 5 years. There's actually been several meta-analysis of this. And so it really is important to start as low as you can. And we really should be aiming for an EOA of 2 as we move to younger patients that are going to be active. So in summary, the refinements and standardization of our deployment techniques have really made complications fairly uncommon, and our outcomes are really good. So we're looking to fix up other things. We're looking at patients that now are younger, they have a longer life expectancy, they want to be active, and so they need a valve performance and durability that is going to suit their increased life expectancy. Now remember that once we put any prosthetic surgical valve in there, you're not going to live up to the normal life expectancy. So, you know, a 65-year-old has a normal life expectancy of 22 years. After surgery, it's probably a little less than 20 years. So, you know, but we still need to get a fairly long durability of these valves. We really want to provide optimized hemodynamics. It's really critical, particularly in these younger patients. We really should be looking for EOAs of 2 or above if these people want to be active. And we really want to get as close to normal hemodynamics as we can. And of course, durability is really heavily dependent on both the initial hemodynamics and how these hemodynamics move forward. We know that surgical valve durability is based both on how the tissue is treated and the design of the valve. We've seen that our externally wrapped pericardial valves, the MitraFlow and the trifecta, they failed early. We published an early paper on trifecta failure in 2017. And recently there was just a big paper out of the Cleveland Clinic looking at almost 5,000 valves, half of them trifectas, half of them pericardial valves. And again, the internally wrapped, the externally wrapped pericardial trifectas failed early. So valve design matters. And right now, the superannular platforms have improved and superior hemodynamics. Certainly, some of that has to do with the valve design itself. Long-term durability over 10 years, we really don't have yet. But again, up to Notion, we're up to 8 years. I've talked to Lars Sarnegard. They really do have some early 10-year data, but it's not published yet. But I do want to reemphasize as we move into younger patients, they're not only going to live longer, but they're going to be more active. We're used to looking at echo reports on a patient sitting in the cardiologist's office, sitting still doing nothing. We have to remember most of the time they're not sitting still doing nothing. They're actually out there living their life. So Paul, I'm going to end there, and I'd be happy to answer any questions. And I apologize, as you can see, my OR was yelling at me through the door. So.
Well, we appreciate you multitasking there, Michael, and a fabulous presentation while being distracted by whatever's going on in the hospital.
Yeah.
Some questions for you, and I always learn something when I listen to you. This EOA of 2,
Yeah.
you know, so how often are we getting there?
Well, I think,
and I want to ask for both transcatheter and surgery, because you know you have young patients patients who don't want mechanical valves. I mean, how do you manage that discussion? And if somebody is younger and wants a EOA of 2, do you choose TAVR over SAVR?
well, so if they have a small annulus, TAVR tends to do better. But I'll say, Paul, in my operating room, we have a rule that if you're a female, you do not leave and you're getting surgery and you're getting a tissue valve, you do not leave with less than a 23. And if you're a male, you do not leave with less than a 25. Bo Yang at the University of Michigan just reported this really nice annuloplasty called the Y annuloplasty. It's much better than the old Nix or Manugian. And I can always upsize 2 sizes from predicted and usually 3 sizes. So if they come in and I predict I'm going to put in a 19, I can usually put in a 23 or 25. And so we're much more aggressive about upsizing now. And then my other rule is that for any prosthetic valve, a DVI 0.5 is what I consider kind of the baseline. You should be 0.5 or above for the Doppler velocity index. And that corresponds to an aortic valve area for an average sized person of about 1.8. You really ought to be bigger than that.
So when you have a younger person or somebody who wants a tissue valve and you have thoughts about EOA and such, and your goal is 2 or so, And you showed data on some surgical valves being better than TAVR valves, but some TAVR platforms are bigger than surgical valves, depending if they're supraannular or not. Do you have a discussion about doing a supraannular TAVR valve instead of surgical valves in some situations?
Yeah, I do. And some of that depends on the height of the coronaries and whether I think I'm going to put a second TAVR valve in there safely. And then my other discussion is if we're going to do TAVR first and you're young enough, I may have to actually take that out at some point and do surgery. And the early data on that is the risk ratio for doing that is 2 to 3 versus just doing an AVR. I've actually done 19 TAVR removals and surgeries. I've only had done one root replacement, but I can tell you they're harder operations. It's not like doing a virgin AVR. So, I saw a guy in the office today who is 56 and wants a TAVR, but he also is healthy as can be. And I tried to convince him, and he's going to do this, that he'd be better off getting a 25 or 27 pericardial valve. And then when he comes back in 10 or 12 years, he's an ideal candidate for all the interventionalists to do a valve and valve, and he'll probably have space for a second valve and valve.
Okay, so I'm going to ask the imagers because we're conflicted. Surgeons want to operate, interventionists want to do TAVR, but the imagers get to see all the garbage. So Omar, what do you tell a young person who comes to your office and wants a tissue valve and doesn't want anticoagulation? How do you manage that conversation? Let's just say they're 60. Tell us your approach to talking to them.
Yeah, so I think one of the concepts which Mike touched upon is the lifetime management. So what is going to be your lifetime management? So if you're going to have one or two other procedures or surgeries, and I think that's very important. And the other related point is your surgeon going to be aggressive in root enlargement, annular enlargement, because all surgeons may not be trained well in that or not as aggressive perhaps. So I think it's important to know who you're sending your patient to for surgery as well.
Okay. And I'd just like to second that, Omar. If you're sending people to surgery and they're sending you back 19 valves, you need a new surgeon or just do TAVR. Because if they send back a 19 valve, they've failed you, they've failed the patient.
Okay, so Nadir, so tell us about your approach. Somebody who's young, who wants a tissue valve. How do you talk to them about longevity? Let's say they're 60 and they're interested in wanting a tissue valve. What do you say about the expected longevity, and are you satisfied with current TAVR platforms? Do we need to innovate more?
Thanks, Paul. I think I concur with what Omar and Dr. Radin mentioned. I think, it really depends on the surgeon that you have, really, and having that long conversation with your patient, really, in terms of their expectations, in terms of lifetime management, in terms of anticoagulation. And also, once you have that large valve, like what Dr. Radin and Omar say, you can actually subsequently do the valve in valve, once that valve fails. And I think with the current innovative technology, I think, with the, in terms of durability, improving the hemodynamic performance, I think, and getting larger EOAs, I think that is very important and key to having this innovative technology to help improve the current TAVR platform.
Yeah. Alan, anything in addition there in terms of the discussion?
No, I think I echo everybody's concern in that we need to start, the larger is better, particularly with any prosthetics. I think we are encountering a little bit of a problem as more patients want TAVR, and the surgeons as talented as Mike and all of his contemporaries, may begin to slow down over the next couple of years. The idea of the annular enlargement is something that not everybody is very fluent on. And I think if we can try to emphasize that for the treatment of patients, that'll be critical for all of us in the future. I mean, we're interventionalists. We like placing the TAVR prosthetics, but we're also cardiologists, and we want to make sure we do the right thing for our patients as well. So surgery is a good platform as well. We just want to make sure that it is a platform that's appropriately utilized for everybody who would benefit from it.
I'm particularly struck, Michael, by your ability to enlarge 3 sizes. That's really expert.
What is really based on this new annuloplasty that Bo Yang has put out, and I think it's going to fundamentally, because you don't have to even cut into the mitral valve. It's just right at the annulus. It's very easy to do. It's very safe. I've got a cardiac surgery kind of super fellow with me. He basically does them all. I help him. He's now done 14 of these himself, and as a fellow, and it works out really well. So we need to train the surgeons to do this. And this is like, you would never send a coronary bypass to a surgeon that didn't do mammaries. You'd quit sending them. You shouldn't send cases to surgeons that send back 19 and really even 21 valves. It's just not right.
Yeah, there's clearly a need there, especially with the next presentation where we talk about PPM. A 19 or 21 size valve means a lot in a large person. So with that, Nadira, we'll have you go next and talk about PPM and TAVR design and how that impacts it.
Okay, thank you. Good evening, everyone, and thank you, Paul, CVI, and Terrace, for the invitation. It's such an honor to be among an esteemed faculty and in this webinar. And today I'll be talking to you about the importance of PPM and the TAVR design factors that impact it. I have no financial disclosures. So we do know PPM, the definition of it is that essentially it's a normal functioning valve, but essentially it's too small for the patient's body surface area. This patient, when you index the EOA, is really small. They are left, as you've heard from the other speakers, with high residual gradient post-AVR with a mean gradient of more than 20 millimeters of mercury. And as for the VAC3 definition of PPM, these patients in the moderate to severe range, the valve structure and motion is normal, but the definition of severe, anything less than 0.65 in terms of the index EOA. And for patients who are obese, who are BMI of more or equals to 30 kilograms per meter square, is when your severe, PPM is less than 0.55. So what do we see in the literature in terms of PPM in the surgical literature? So really using, based on the STS database, any degree of PPM, as you heard from Dr. Ritter, and really you have these patients don't do well in terms of survival, increased hospital admission in terms of heart failure and reoperation for the AVR. How about PPM in the TAVR literature? Similarly, in the STS ACC TVT registry, you can see, looking at the data from 2014 to 2017, that PPM is seen in about 12 to 25%, respectively, in terms of severe or moderate PPM. And these patients are associated with increased mortality, heart failure rehospitalization at 1 year. And what are the predictors of it? As looked by Dr. Herman in 2018, that these patients are implanted with a small valve size, they are female, they're younger age, they have a lower LVEF, and also these patients, some of these who have PPM is due to valve-in-valve procedures. And looking at all the current literature, you can see there's a huge variation actually in terms of the definition of PPM, the incidence of PPM, and ultimately the impact of mortality of PPM in the TAVR literature. The question is, why is there such a variation in the TAVR literature? Really, that's because of how the method of gradient determination, is it by echo or is it by CAP, the method of EOA calculation. And as again, like I mentioned, the timing of these measurements, is these measurements done on the table or is it before discharge? Because these patients have different hemodynamics while the patient was in and during anesthesia. In addition to obesity of the patients as well, the PPM as well changes. Well, in terms of the severe PPM on outcomes, it is also conflicting in the current literature, and that's because of the incomplete correction for confounding factors such as PVL. Some of these analyses are underpowered, and they also have limited follow-up in terms of 1 year follow-up, which may not be sufficient. But really the question is, where does it all matter? It does matter in terms in the literature, in terms of the valve-in-valve, patients with low flow or low EF, like Dr. Redden mentioned, in the young population, the younger cohort, and these patients are also active. And I cannot stress the importance of imaging. Really, in terms of, for echo is the first line in terms of assessing this valve, whether to determine whether it's a normal functioning valve, whether there's a patient prostatic mismatch, or whether there's any suspicion of valve stenosis. And of course, you would then perform other modality imaging like TEE or CT to further evaluate it. And in terms of echo, there are limitations and flaws, as you heard before by the previous speakers. We can overestimate the ppm by indexing as measured by echo. We underestimate the LVOT diameter and hence your effective orifice area. You can overestimate the gradient depending on where your pulse Doppler is. Underestimation of the EOA due to pressure recovery. And also we see a lot of low flow state, and that you see in about 35 to 40% post-TAVR because these ventricles are very thick, they are small ventricles. The volume is really small, really low, and so you get what we call a pseudo ppm. And so more recently, Julian Tanakel and Pibero's group published recently in terms of the different methods of measuring ppm. So is it by measured or predicted EOA index? So the measured ppm is usually used by the continuity equation and really by indexing to the body surface area. Now, in terms of the predicted ppm, there's two methods of measuring it. So the first method is really based on the normal reference value of the EOA in terms of the size and type of the valve, as published by Dr. Han in the table on the right-hand side, which is for the balloon expandable SAPIEN valve. And the second method is for the SAPIEN 3, and it's really based on the normal reference value according to the aortic annulus, which is the CTA. And so with this method, what they did was really relook at the cohort of patients. And so really looking at the impact of ppm by comparing the measured and the predicted EOA index. And they found that the incidence of severe ppm really is lower when you use the predicted EOA index. And TAVR overall has a lower incidence of severe ppm as compared to the surgical AVR. Now, in terms of the impact of ppm on outcomes in the surgical cohort, the severe ppm, which is by the predicted EOA index, is really rare. And if it does happen, it is associated with worse outcomes, which we know in the current literature. And in the TAVR cohort, severe ppm by the predicted method is really absent at all. But if you combine both the surgical and the TAVR, moderate ppm is not associated with worse outcomes. And they went further on to look at their own real-world data in the single institute in Canada. And they also found similar findings in terms of the overall and severe ppm post-TAVR is really 2 to 10-fold lower when you use the predicted EOA index. So really that if you use the predicted ppm, it has a stronger association with transprostatic gradients and the occurrence of higher residual gradients when you compare it to your measured ppm. And then none of these is associated with clinical outcomes. And they found in their cohort the main factors that is associated with ppm is really the type of valve, whether it's a balloon expandable or a self-expanding valve, and also in the valve-in-valve TAVR. And the question comes back to, does ppm matter in TAVR, or is it becoming obsolete? You know, we are seeing less and less severe ppm in the current literature based on the predicted EOA index, but it does have an impact on structural deterioration of bioprosthetic valves. It may have a minimal impact in the short-term outcomes, but ultimately it impacts and impairs the TAVR durability and thus have a negative impact on the longer-term outcomes. And as mentioned, I think ppm matters in women in valve-in-valve procedures, low flow, low EF, young patient in the cohort as we move towards the lower risk cohort, and also in smaller annuli, when of course there's ongoing trials, which is SPOT trial, where they randomize with patients who are less than 430 millimeters square on this cardiac CT to balloon expandable or self-expanding valve. Now, what are the potential strategies on prevention of ppm? As you heard from the previous speaker in terms of the design and the valve selection, the implant technique, and also new designs such as Dura AVR. We heard the Dura AVR transcatheter, it has both the balloon expandable and supraannular features. It has other features in terms of the 3D shape and the single piece construction. And as you see in the previous speaker slides, the proven adapt tissue, which is acellular, non-toxic, and anti-calcification features and properties to help with the durability. In terms of the valve design, I think it's really important, the impact of it in terms of sustaining hemodynamic function, the 3D shaped leaflets, and the single piece construction. Ultimately, the longer coaptation can help provide a larger EOA, greater coaptation area, the lower leaflet stress, and ultimately an optimal laminar flow. And of course, we look forward to further studies and early feasibility studies in terms of this valve and this new innovative technology. So in summary, I've shown you the differences between the SAVR and the TAVR literature, and I think we need a common language and the need to use the predicted EOA index in larger series with the other types of TAVR valves and longer follow-up, especially as we look into the younger and the lower risk cohort. Of course, PPM impact the TAVR durability and ultimately negatively impact the longer term outcomes, and looking forward to the innovative technology which creates a really unique opportunity to address the durability and hemodynamic performance. With that, thank you very much.
Wow, that was fantastic. I think certainly nothing short of the controversy around PPM that unfortunately you don't have the luxury of resolving in that short presentation. I struggle with PPM. I mean, and when I grew up around surgeons and even cardiologists, you know, we grew up in this background that PPM really matters. And then all this recent literature, it gets to be really confusing. And to be honest, I can't wrap my head around it. I mean, what I mean, is it mostly patient driven? You know, in terms of the outcomes, you know, you mentioned low flow, low gradient, women, valve and valve. Is it more of that than the actual valve design, or how do we put the two together when we talk about PPM with our patients and colleagues?
Great question. I think it's a dilemma that we see all the time in our clinical practice. You know, we see like in at least 40% of patients, they have this low flow, and you get this low EOA, and you think that this, you know, really the valve area is not accurate. But I think the key in the current literature is really using that, you know, that predicted EOA. I think that is really important, you know, and I think having that reference values to that valve. Of course, you know, it's tough because like the paper by Dr. Han, these are all core lab adjudicated data from the partner trial and the core valve trials. And I think that's what we need. We need more data. We need more, you know, studies to really look into this. And so that we are able to compare apples to apples. And I think that is what is important, especially in the TAVR literature, because the differences in the variation in the, you know, in terms of the measurements of the PPM, I think that's what puts everybody a little bit confused. So I think it's really speaking the common language. And the second point being, you know, the measurement, I think is very important, really standardizing the important. And so obviously there are guidelines in terms of measurements of the LVOT diameter for these post implantation of the valve, and also measuring where your pulse wave Doppler is. I think these are important echo key measurements that need to be, you know, advocated and performed so that everyone is, you know, measuring at the same stage, basically.
So when we're having this decision making about TAVR versus SAVR, and obviously we've touched upon different hemodynamics in terms of gradients and EOAs earlier. How do you factor in PPM in terms of calculating it in that decision making? Do you predict the EOA by SAVR and also by TAVR and compare the two? I mean, it's because you mentioned that there are different methods of assessing for SAVR versus TAVR. How do I, as a clinician, how do I calculate it and predict it and help me choose between the two platforms?
That's a great question. I think, you know, it's important, I think, really in terms of multimodality imaging, knowing the annular size. And I think besides echo, I think that's where CT comes in assessing this patient, you know, regularly to see what is the aortic annular area. You know, I think in multiple of our discussions, like our valve meetings, whether would this patient benefit from a SAVR or a TAVR, what size valve fits this patient. And if it's a small annulus, like, you know, would you do a root enlargement? What is the surgical risk? So these are all the questions that we ask, you know, at our valve meetings. And we have that discussion, would this patient benefit from a SAVR or TAVR? Putting in a 26 balloon expandable, what is the expected EOA for this patient? And having that reference value is key, and as knowing what the BSA for the patient as well, taking into consideration that factor as well, I think is key in the decision making.
I know Michael's going to say bigger is better because he's already said it before earlier. So I'll ask Alan. Alan, you have experience with multiple TAVR platforms. Do you use it in terms of PPM and thinking about choosing one valve versus another?
I think the concept of how we address PPM or how do we try to choose the valve will depend on the patient. It's not the same to have a patient that has severe concentric LVH, which gives them a very small annulus, as opposed to the patient that has a very large annulus or a normal sized annulus, but unfortunately is morbidly obese. I think that concept comes into play a lot over the outcomes, and also potentially what is the level of activity of the patient. The younger person who continues to exercise or as a marathon runner probably will experience a different effect on the hemodynamic profile than the elderly that doesn't necessarily move as much. It does come to play, and we do try in our valve meetings to try to discuss which of the two prosthetics that are available will obtain a higher EOA, and then whether or not the patients would be, whether or not the procedure would be equally as simple or equally as effective. We don't always want to place a valve in a certain position, sacrificing a pacemaker rate for coronary reaccess or things of that nature. So I think looking for the right combination for each patient is our best option.
So with that, we're going to have Omar speak to us. We're going to go beyond EOA. His topic is novel parameters beyond EOA and mean gradient for assessing valve performance. So Omar?
So this is just a slide of the existing guidelines, which are very old, all the parameters we're used to. We know that we use the continuity equation. This has been well covered in prior talks. But before we go beyond, we need to know what are the pitfalls of the traditional assessment, which I think are a big part of the issue. So going back to 2012, this paper from our center showing that pulse wave Doppler inside of a balloon expandable valve will demonstrate flow acceleration depending on whether you're at the edge, a little bit inside, or further inside. And further work done by our group, we tried to figure out what is the best place to do these measurements, the LVOT diameters. Is it prior to the TAVR, after the TAVR, at the annulus, at the edge of the frame, inside the frame? And to simplify this busy slide, what we basically found was that the most reproducible was actually the pre-TAVR LVOT diameter, followed by the post-TAVR LVOT diameter at the edge of the frame. And moving along to the self-expanding valve, this is a manuscript in progress. The self-expanding valve is a little bit different in the sense that if you use the LVOT pulse wave VTI at the same location as the diameter at the edge or inside the frame, it actually demonstrates a different pattern than the balloon expandable valve. So as long as you match the locations, actually the EOAs are very consistent. So the valve design also matters in the sense of what technique you're using to get the EOA. This is the paper shown in the two prior talks of the normal values from the core labs. In this paper, they use the edge of the stent, so post-TAVR outer to outer stent diameter in the LVOT, combined with the pulse wave at the same location to measure these standard reference values for EOA. And the range of values here was between 1.1 and 2.6 centimeters squared. So a significant number of values below 2 centimeters squared for transcatheter valves. So just to summarize, using the LVOT diameter pre-implant or post-implant with ideally the pulse wave at the edge of the stent, but sometimes we get these short LVOTs or low implant depths where we can try to match the diameter inside the frame with the pulse wave, but this will tend to overestimate the EOA in a balloon expandable valve. And the self-expanding will give you a consistent EOA, but will probably overestimate your dimensionless index due to flow acceleration. So in summary, just to reiterate, we need the correct location of our LVOT diameter. We want to make sure that it's not foreshortened, and that's in the realm of stenographer training. We need the pulse wave at the edge of the frame or in the matching location for the diameter. And we need to get our continuous wave Doppler velocity from multiple views. So the point to drive home here is that there could be multiple sources of error for gradients, dimensionless index, and EOA calculations. So what are the concerns in these early reductions of EOA in the first few months? So we've talked about this. So Halt, right, leaflet thickening, ham, turkey version for me, no pork, hypoattenuating leaflet thickening affecting motion, and then the general term of reduced leaflet motion. So what does this all mean? So this is usually related to leaflet thrombus. This was one of the original papers, Lancet from 2017. And this could be an early nidus for valve degeneration, which I'll discuss more. And an important thing here, which we mentioned in some of the discussions, is that these are relatively small changes and subtle. So a mean gradient of 14 versus 10 for patients with reduced versus normal leaflet motion. So very non-detectable changes in many cases. So going across trials, reading the literature for reduced leaflet motion, maybe absolute changes of 4, very small values in the mean gradient, relative changes of the mean gradient of 50% perhaps, dimensionless index of 0.14, percentage of dimensionless index of 21%. And then when we go into the realm of possible stenoses, slightly different changes relative to the original. But the main point here is that you need a high index of suspicion, and these changes can be very subtle on the echo. Moving on to the VARC3, which was mentioned previously, it's really about the relative changes, as we mentioned. So stage 1, kind of seeing thrombosis or other changes without significant hemodynamic changes. Stage 2 with mean gradient changes of 10 or greater. EOA changes of 0.3 or 25%, and dimensionless index changes. And then stage 3 with further deterioration of these numbers. So it's really all about getting the original values and then comparing it across time. So what is the clinical impact of post-TAVR thrombus? Well, in the Partner 3 sub-study for CT, there was really no difference in Halt between SAVR and TAVR at 1 year. There were minimally increased gradients, as we've shown. 50% of the patients with Halt at 30 days resolved at 1 year, even without anticoagulation. 20% without Halt at 30 days got it at 1 year. And there was no detectable clinical impact in this small subgroup. And the Evolute CT sub-study showed similar findings as well. And in this Galileo 40 CT sub-study regarding use of rivaroxaban, there was a reduced incidence of leaflet thrombosis at 90 days, but with increased risks of death and bleeding in the main trial at 17 months. So in summary, there's no current role for routine cardiac CT since the modification of the leaflet thrombosis is still unclear. But what about the progression from the long term? So far we've shown the short and midterm data, which we have. So this is a histopathological study of TAVR explants done by the Vancouver group, which showed a very clear progression of a first stage of thrombus, a next stage of fibrosis, and then followed by a final stage of calcification and structural valve deterioration. The same group has published small data sets of surgical valves, which show exactly the same progression. So early data, but it seems to have the same pattern. So we may be underestimating this pattern in surgical bioprosthesis as well. So theoretical, keyword theoretical, because we don't know for sure the key features for TAVR in younger populations. We want to focus on durability and performance. So reduce leaflet stress, leaflet thrombosis prevention beyond anticoagulation, commissural alignment, coronary protection and access, larger EOAs, perhaps above 2, and pacemaker prevention, which has shown increased mortality signals. But the key here is we need much better understanding of modifiable predictors of transcatheter valve durability to see whether we can really change this. Thank you.
Thank you very much, Omar. I think it's the whole discussion about Halt. It's
Can I get and monitoring the room?
We weren't even talking about Halt until the paper on subclinical thrombosis came out almost 10 years ago. I mean, it seems like forever ago that came out. But do you think I'll just tell you in our practice here in Minneapolis, we do TAVR CTs on all our patients at 30 days, unless they have a renal issue or they can't come for the study. But we prospectively do it, and we manage our patients with anticoagulation depending on the findings. I don't think we've seen a particularly higher incidence than what's been reported in the literature, but we do screen for it prospectively. Do you think that we're missing these in the usual practice when we're not using CT? And Omar, do you think we should be using CT to look for Halt and act on it?
I think that's a hard question. So obviously it involves a lot of extra testing with an unclear impact of the treatment of whether we're really modifying the prognosis. I mean, on a theoretical basis, I would think that we would modify the durability of the valve in the longer term, which we don't know yet. But I think right now that can be a tough sell. And you also need, a good CT imaging group, good imaging quality, and the ability to get your patients back to do that. So I think those are the factors which also make it more difficult at the current time.
And when you see Halt in your imaging analyses, are there particular predictors or features of valve prostheses or how they're deployed or such that you can say that this was associated with Halt or something that's modifiable in your practice?
I mean, I don't know. I don't have a great sense anecdotally, and also the data I've seen in papers and abstracts have been very mixed. Some show more expansion, some show less expansion, larger valve sizes, smaller valve sizes. So I think it's a bit confusing right now, and harkens back to my last statement that I think we really need to clarify what are the predictors for this and how can we modify it.
Michael, what do you think? Do you think we're underestimating Halt and Han?
Well, I think we are underestimating it. The problem, of course, is that it's so heterogeneous. I mean, when the data came back from the Evolut low risk trial and Philip Blanque was going to present that for us, and I was looking over this data, my first thought was, what am I going to say about this? It comes and then it goes, and it's just all over the map, and I could find no way of predicting when it was going to come, when it was going to go. And we just can't put all these people on anticoagulation because these are older people. And, as we saw in Galileo, they bleed, they die, bad things happen. And in surgery, you're not old enough to remember this, Paul, but when I was young, we put everybody on Coumadin for a while because we wanted to let the knots heal in. And then we quit doing it because it didn't make any difference based on some very large studies from Mayo Clinic. And now we're starting to do it again based on one study from Sweden. So we as surgeons in 60 years haven't figured this out yet. I just think it's going to take a while to figure this out in TAVR, right? It's something we need to keep working on. It is, as our imaging gets better, we're going to find more and more subtle changes, and we're going to wonder what we're going to do with them.
Alan, how do you manage the risk of Halt or findings of Halt in your practice? There's a question in the chat about whether these patients should be on NOACs, Coumadin, or nothing, or depending on the hemodynamics. What do you do?
So we routinely just follow our patients with echo. We don't do routine CT scans on everyone, but any increase in the gradient, even as low as 3 or 5%, actually would warrant future investigation. And we then anticoagulate them. The majority of the patients don't like warfarin. Unfortunately, getting the NOACs approved by insurance companies makes it difficult because the presence of Halt is not an approved indication for these anticoagulation medications. So we routinely use a NOAC if that's covered by insurance, and then for a period of 30 days, we try to stop anticoagulation once we prove that our gradients have returned to normal or that the Halt has disappeared, and then re-image them again in the near future. And if there's reoccurrence, we then transition to lifelong anticoagulation.
I mean, certainly echo is the most widely available and easiest to use to screen our patients for any evidence of abnormality. But Nadir, I mean, when you look at these echoes and you see these in your core lab work, I mean, are there features you see that would tell you that, oh, this looks like it could be Halt? I mean, other than frozen leaflets, I mean, I think that's pretty obvious. Even an interventionist could see that. But I mean, are there just other features that you would pick up that are more subtle that would just clue you in?
Yeah, we do see it. And I think the key is really good quality transthoracic echo. It can be very challenging. And like what the other speakers mentioned, the first sign is your elevator gradients. There may be some views really using that multi-parametric approach, using all the multiple views to really assess that leaflet. It can be challenging for your parasternal to your short axis, to your apical views, or even your subcostal views. And I think if there's any sign with the elevated gradients, proceed with a transesophageal echo, or if the creatinine is, normal, proceed with a CT. I think our threshold in our practice is really low. Once we see the elevated gradients or we have any high suspicion, really move on to either CT or transesophageal echo.
I mean, Omar, however it's detected, I mean, do you think that it's worth having some designed or modifiable way of addressing the risk of Halt or its development based on what you think of in the literature?
Yes, just going back to your prior question, then I'll answer this one. I think the numbers that I showed in the slide of those relative changes, I think that's what I use when I look at the follow-up echoes, and that's a frequent question we get, especially when, MD and the patient's primary cardiologist outside got an echo and they thought there were increased gradients, right? So then you really have to look back. What were the changes? What were the LVOT diameter that everybody measured? Do you use the same one? Do you use a different one? To really hone in on whether it's a real change. And then if there's a question, we would move on to the CT. So that's kind of the algorithm for us. And then in terms of the second question, I think it's very important. I mean, those histopathological studies pretty clearly show the progression from thrombus to fibrosis to calcification. And then sometimes the question becomes, well, they continue to have high gradients. And should we do lifetime anticoagulation? But once you're in that second and third stage, I'm not sure it really matters anymore, because that thrombus is really fibrosed in, and there are other things on top of it, and I don't know that it modifies it anymore. So I think preventing that first step would be very important, and ideally by other methods than anticoagulation, which we already know in the older populations can cause increased bleeding. In the younger, maybe okay, but still unclear. So I think some type of leaflet technology or implant techniques that would really prevent that first incidence of Halt, I think would be very important.
I mean, it seems like to me that if it's affecting 10 to 12% of the patients, it's a pretty sizable population, especially since we're probably underestimating it. But anyway, we're past time, and I want to thank our expert panel for this wonderful discussion. I think we've learned a lot, and it's always great to see you all. And hopefully we're continuing with be able to address COVID and exit sometime in the future to where we can be around each other more. And I look forward to seeing you all in person really soon. And I want to thank you all again for joining us, and thank everyone for participating and the audience with the questions. So thank you all.